Hi, everyone. We'll be starting in just a minute, just waiting for everyone to join. Okay, maybe we'll get started, and I'm sure a lot of folks will join in a bit later. So good afternoon, everyone, and welcome to our webinar, Learnings from Primary Care Vaccine Rollout across Ontario. I'm Kavita with AFTO, and I've got Bryn, Beth, and Sandeep here from the team, and we've got a panel of speakers that are going to be amazing to talk a little bit about how primary care has stepped up during the vaccine rollout and just generally during the pandemic, and I'll introduce them in a minute. And I think what we just wanted to highlight in today's webinar is we know primary care has played a pivotal role in the pandemic, and celebrating those successes and celebrating the great work that you're doing in the field is really, really important. But learning from each other is also just as important. So we really hope that there'll be some nuggets that come out of today's session that you can take back to your planning tables as we start planning for phase 2 and 3 of the vaccine rollout. But before we start, and I know you're all familiar with this, just the housekeeping. So I'll just maybe go to the next slide. This is Zoom. You all know how to participate. We are going to ask that if you've got questions, could you put them in the Q&A box? We will monitor both the chat and the Q&A, but if you could actually ask them in the questions box, we'll be able to address them during the presentation. And next slide. So we have an amazing panel ahead of us, and you'll see the names here. We've got Jill Berridge from McMaster Fit, we've got Robin Mackey from Delhi Fit, Michelle Lejeunesse from Marathon, Terry Arani from Toronto Western, and we're going to start off, and we're so happy that Dr. Daniel Warshawski and Nadia, I don't know if Nadia's on, but Daniel is here from the Chief Medical Officer of Health's office. And I know a lot of folks just want to hear from the ministry. They just want to know what's going on. So we really are happy to have Daniel here just to give a bit of an overview of what's happening right now with the vaccine rollout, looking at how primary care is playing a role in that. And then, as I mentioned, if you've got questions, if you can put it in the Q&A, we'll make sure that we get them to Daniel. So maybe we'll start because we have a big agenda. I'll get Daniel to start and just give us a bit of an update. Over to you.
Thanks, Kavita, and hi, everybody. Glad to be here. So I'll give just a brief update on kind of the current status of the vaccine rollout throughout the province. So obviously, we're still in our phase 1 of vaccine rollout, although it is progressing along better now that we've passed that kind of rough spot with the Pfizer shortage. By and large, most residents of long-term care homes in the province have now been vaccinated. It is a little bit dependent on the local public health unit and region in terms of supply, but most and getting very close to all residents of long-term care homes are vaccinated as probably within the next week or two. And yeah, we'll be including getting their second dose. In terms of the rest of the phase 1 rollout, now that, again, as I said, we're past that Pfizer shortage, we're expecting quite a lot more shipment of vaccine to come in over the next month before the end of Q2. So the estimates we have federally, so countrywide, are about 3 million doses, probably over the next month should be coming in, which means for Ontario about 40%, so roughly 1.2, 1.3 million doses, which is along what we were expecting for the actual distribution. So at this point, we're very confident that we can still complete all of the phase 1 priority populations by the end of Q2. Again, and I'll emphasize this probably many more times before I finish speaking, is that it is all local public health unit dependent and driven. And so we will see variation based on the geographies and demographics in terms of the rollout, but we do expect to be completing phase 1 pretty much on schedule. The prioritization process, so determining how phase 2 is going to roll out, is nearing completion. And we expect that priority group list will basically be made public probably within the next week. And that will give the breakdown of things like what age ranges we're doing, what medical comorbidities, and then moving into things like essential workers and other services, as well as congregate settings, and then particularly marginalized and vulnerable communities. And that will all be in that prioritization rollout that goes, so that we have a really clear understanding of who's going to be vaccinated at what point in time. The rollout process, as I said, is being coordinated through local public health and will be even more through local public health as we go forward, especially when we have more new vaccines online, such as AstraZeneca, which we all just heard was approved this morning, which was actually a little bit of surprise to me as well. I thought it wasn't going to be for another week, just what we heard lately. We initially thought it was going to be last week, and then they were delayed, but we're all happy to hear that it has been approved. We are expecting shipments of AstraZeneca fairly soon, given how quickly most of the other vaccines we've seen things come in after the approval, so probably in the next 1 to 2 weeks. In terms of the AstraZeneca, this is really helpful because obviously this is a fridge stable vaccine. We don't need any freezer at any time. And so that really means that we can get it to a broader population and through potentially other channels than we are at this point. The AstraZeneca is a very effective vaccine against severe COVID. So in the trials, there was nobody who was hospitalized, nobody who died, no one who had ICU admission who had been vaccinated. It's less effective overall against symptomatic COVID than the other vaccines. But again, in terms of against severe outcomes, it seems to work extremely well. It has not been decided yet specifically what groups will be delivered this vaccine. And that's something we expect to hear more soon now that the approval has actually come out. In terms of primary care involvement, again, it's going to be by local public health unit, how you're involved. I know that in many public health units, primary care is already heavily involved, whether it's going to long-term care homes or helping to staff some of the larger clinics that are going on. And I know that primary care in many health units has been involved in the future plans and rollout and how it's working. We're probably for the short future still expecting things to be mostly done in mass vaccine clinics. So it's unlikely in the next couple months that we see it going directly to primary care offices. But primary care will still be heavily involved in those clinics. And again, we're going to see more mobile groups. So thinking of things like home care patients who may need additional support in order to get vaccine to them. We'll probably see more mobile testing, and I could easily see primary care volunteering and stepping in that direction as well. So in terms of how to stay involved and be aware with what is going to happen in the rollout in your region, your number one would just be to make sure you're connected through your primary care leaders to the local public health unit. And I know there's a lot of connection that's been made in terms of that rollout going well. I guess the last thing I'll just speak to quickly again, since the AstraZeneca has come, is the role of the vaccines and how it plays with the variants of concern. I know we have a lot of questions about how well they cover variants of concern, if we're going to need additional doses along those lines. It's still pretty early in terms of the evidence. We know that the vaccines we have right now, especially the Pfizer and Moderna, but also AstraZeneca, are effective against the UK variant, which is the predominant variant that we're seeing right now, slowly increasing in Ontario. We don't have data that is quite as strong at this point on how well they work against the Brazil or the South African variant. Particularly for AstraZeneca, it seems like it's not as effective against some of those variants. We've seen South Africa has temporarily paused some of their vaccine rollout with AstraZeneca because of that, but we're waiting on a little bit more evidence to determine exactly what we're going to look at. But again, at this point, in terms of what variants we expect to see circulating in Ontario, it's primarily the UK variant regardless, and we know that the vaccines we have are very effective against that going forward. I'll pause there because I know we have a lot of speakers and a lot of questions, so happy to answer anything that's coming up.
Great, thanks Danielle. It's just always so nice to hear from the ministry and get these current updates, so I know it's much appreciated by our members. We do have a few questions coming in. I think top of mind for folks is that AstraZeneca vaccine, some good news that we heard today. The question is, will the ministry be preparing an FAQ document on how AstraZeneca will differ from the Moderna and Pfizer, and how primary care can address any concerns by patients that are not receiving an mRNA vaccine if they receive the AstraZeneca one?
Yes, so absolutely. So we're working with CEP, Center for Effective Practice, as well, to make sure we have enough tools that are out to be able to make sure everybody has the knowledge that they need for these vaccines going out. We expect to have the basics, like the vaccine information sheet, the aftercare sheet, pre-packaged sheet ready for AstraZeneca and posted probably early next week. And as well, we're working just specifically at that point about an additional comparison document about educating around AstraZeneca, because it is a new type of vaccine that we're seeing for the vaccine rollout in Ontario. So we're looking forward to having them very soon. probably within the next 1 to 2 weeks, we'll have quite a few additional pieces of guidance that are going out that will address those issues.
Great, thank you. And just follow up to that with AstraZeneca, do you anticipate that primary care offices could receive those vaccines directly to be able to vaccinate more patients in clinics?
Yeah, that's a really good question. And as I said before, and I'll keep saying, it'll probably be dependent on the local public health unit and the specific needs of the communities that everybody lives in. I think, in somewhere like Toronto, no, I'd be shocked if that was a route that they went. But particularly for more rural, sparsely populated health units, especially some of the northern ones with longer distances between places where it's harder to hold a mass vaccine clinic, I wouldn't be surprised if we see more of that going out. But again, I would just encourage people to follow up and work with their local public health units as closely as they can.
Great, thanks. Good advice. Can you mention, or do you have any comments or information about the provincial patient booking system that's being developed for vaccine appointments?
I have just a little bit of knowledge in it, in that there was a tester that we just saw earlier this week. So it is looking good, and it should be something that is coming out soon. It's, to this point, it's still a lot of local public health units having their own registry systems. I know many of them have already put them online and they're being used. What we'd like is to have the provincial system available for everyone, and it'll be a little bit easier with that system to get data kind of right into COVAX, because you'll be able to register with your name and hopefully your OHIP card. We'll know your age. We'll know that you meet a priority population that's valid. So we'll have more information on it soon, but at this point, I don't really have a good timeline on when it's going to be ready, unfortunately.
Okay, no, that's fair. Thank you. Similar to that, then, now that we have a steady vaccine supply, as you've mentioned, we're sort of over that hurdle of the shortage. Will the over 80 population in communities be expediently vaccinated rather than after March 15th, when the booking system will finally be, or hopefully be, functional? Just a comment that other provinces are ahead of Ontario in that respect.
Yeah, absolutely. So that's on the call that we just had this week with General Hillier. He made it very clear that we need to start getting through those other groups. There are quite a number of health units that are already well through their 80 population that I'm aware of. Again, depending on the region, there are differences across the province. Some just had fewer long-term care homes and more independent 80-year-olds living in the region, so they're along the way. Without the provincial booking system, it's still obviously able to do that. So I know that in some health units, there's been reach out through primary care to help identify patients and how to best access them. So yes, we're very hopeful that the over 80 group is going to be vaccinated, very soon. Like over the next month, we expect to get through most of them.
Okay. And again, there might be some variation across the province, as you've alluded to, but do you know how health units will be contacting the 80 plus population, and do they have to self-register?
So it's variation across the province. I know for the ones that are doing it, there's been a combination of kind of broader public messaging, like there's been radio and TV, like in local newspapers saying if you're over 80, you can now register on our website. Some of it, as I said, is helping through primary care to identify the numbers of people that are meeting in those age groups, so they have a better sense of exactly what to do. In terms of over 80, just to be clear, I think we said everybody who is born in the year 1941 or earlier, regardless of birth date, gets the vaccine. They're not going to be checking to make sure, it's 3 days before your birthday, so that makes things a little bit easier. But there is variation. I think it's working differently in a number of areas.
Yeah, and I'll just say to the speakers when they present as well, keep some of these questions in mind, and if they want to share some of their approaches too, it'd be helpful. Yeah. A couple of questions here on COVAX. So we'll mention that one of the rate limiting steps to vaccinating is the training on COVAX. Do you know when that will be rolling out so that primary care providers will be able to access and be trained?
Again, that will be primarily through local public health in terms of how quickly they're needing to onboard additional staff to do it and the types of clinics that are going to be run. Anybody who's volunteering and going to be at a COVAX clinic or who has gone to long-term care is already trained or will be trained. And it's through local public health to identify yourself. At this point, we don't have the supply to roll out broadly to primary care in the province, as I said. So we're early in terms of getting training out to every primary care provider in the province. And once that is part of the rollout, then it'll be easier. But for now, it's again through local public health. If you're volunteering to be someone who's vaccinating soon, they'll ensure that you get the training you need.
Okay. Thank you. We know a lot of primary care providers were using opportunistic visits with their patients. So every primary care visit really is an opportunity to address vaccine hesitancy, but it's also an opportunity for primary care providers to get consent. Our understanding now, though, is that you might not be able to get pre-consent, because once you go through COVAX, you'll have to go through that consent process again. Can you just clarify if teams should still be getting that pre-consent, or if it needs to be done on site during COVAX or through COVAX?
Yeah, that's an excellent question, and we're still trying to work out the best way to do it. So for example, in long-term care homes, we absolutely had pre-consent. We had substitute decision makers consenting in advance. That doesn't take away from the need to then, when you're going through COVAX, still tick off that the consent has been obtained. It can be done in advance. It just has to be then officially signed by the provider who has obtained consent to make sure that we're able to do it. So to make it a little bit easier, we're updating the consent form. We'll be disentangling it from those pre-screening questions, because again, some of those questions are really day of, like, do you have symptoms now, right? Those are day of questions that we have to make sure that we can administer the vaccine safely, versus they don't really need to be part of the actual consenting process. So we're gonna make it a little bit easier in that regard in the next versions of the consent that go out. But yes, I don't see there's no reason that consent can't be obtained in advance, as long as it can be very clearly indicated and received by whoever is then administering the vaccine. So it either needs to get into COVAX in advance, which is not really something we can do at this point, unfortunately, or you sign the form with your patient. They can bring it in and take it then to the provider who will be vaccinating them wherever the site is, and say, I've already consented, and then it'll just make the process a little bit easier.
Okay, great. Thank you. That's great advice to share with the teams. I know there's lots of questions on that one. Also some questions on medical directives and who will be developing them and assuming oversight. So we've heard that each medical officer of health in the local PHUs would be developing them for each region. So do you know if that's the case? And if yes, does it cover all professions who have an immunization in their scope of practice?
Yep. So yeah, to date, it is every PHU, and actually every hospital site also has their own medical directive they've developed. There is a medical directive type piece that's been put out under the Nursing Act that was done by Dr. Williams. I believe that was shared, I can't remember times anymore, last week, I think, broadly with primary care. Okay, last week. So that covers, I think it was RNs and RPNs specifically in that one, but otherwise every local public health unit is putting their own medical directive. Who specifically in terms of professions they're including is up to them. You know, again, at this point, we do have more limited supply, so we haven't had to go broadly to include everybody who could potentially immunize in the medical directives. Certainly when we get to that point, I know I've had health units contact me already about when are we going to go broader and how are we going to do it. That will be something they'll do to ensure that vaccines can be given as efficiently as possible. But again, exactly right, it'll be each local public health unit operating a directive.
Great. I'm just going to jump back to pre-consents again. A follow-up question here. Is there a specific template to use for obtaining pre-consents?
No, so we don't have something separate from the existing consent form. So really there's the script, the healthcare provider script, and the consent form that are meant to go together to make sure that all of the important questions about consent are there and addressed. And really that, you know, in terms of what the patient needs, they need the vaccine information sheet and the package that explains the counseling about the actual consent for the vaccine. You know, for those specific groups and special populations where we have advice about extra additional counseling that may be required. So that's primarily, you know, people with an allergy who need to see an allergist. That's people on very particular immunosuppressive therapies or pregnant individuals. We do recommend they have counseling by their provider that covers some of the additional considerations for those groups. I want to emphasize that it isn't really additional risks in terms of vaccine. The vaccine is still safe, and we don't have even theoretical concerns why it shouldn't be in those groups. It's really just about their situations are slightly more complicated, and it's worth a broader discussion. For pregnant individuals specifically, we'll be coming out very soon with 2 additional pieces of guidance for counseling. So one will be a tool for patients specifically that they can go through as a helpful decision-making tool. And one will be a tool for providers so that they can help do the counseling. It'll be based heavily on the SOGC, but and I always get this wrong, PCMCH, the Paternal Child Provincial Child Maternal Advisory Committee, something like that. They worked on this tool, and they've done user testing with both for the provider and the patient one. So those will be coming out soon. So for that group, we'll have a lot of other really helpful pieces available.
Great, thank you. A question is about pharmacists. So pharmacists have been announcing that they will be vaccinating soon. Just wondering how accurate that statement is, and will vaccines be supplied in the near future to pharmacies?
Yeah, I think that soon is vague, and that's probably the best I can say at this point as well. With AstraZeneca as a more fridge stable vaccine, it's something that we think that primary care and pharmacy could be doing more of. But again, our supplies are still fairly low in terms of what's coming in. I think that, again, there may be certain public health units where having pharmacy distribute or primary care is something that would be helpful as part of the current vaccine rollout. I think realistically, we probably won't see it for several weeks to months before that it's really going out. But we should be just, again, paying attention to what's happening in your local health unit. And if we do find out more about broader provincial things, I promise that messaging will be going out so that it's clear to everybody.
Great. I think we all recognize the process is so fluid, and just trying to stay up to date with some of these items is challenging. So again, appreciate that open communication. A few more questions here to go. I know we only have a couple more minutes left of your time here, so I'll try to just pose a few more. Will individuals who have a health card other than Ontario be eligible to receive the COVID vaccine in Ontario if they work or study here?
Yeah, that's a really good question. So you don't have to have a health card at this point to receive a vaccine. It's preferred, obviously, because it makes it easier for us to track who's been vaccinated. But you can use other forms of ID to get the vaccine. So particularly when we get to some of the marginalized groups, people who are experiencing homelessness, we know that there aren't health cards or government issued ID that are available. As long as you have something or someone, especially if you're in those populations, to vouch for who you are as a person, so we can ensure that you get the right vaccine at the right time with the right doses, that's really what's required. We won't be restricting people based on whether or not they don't have an Ontario health card.
Another question here, if an over 90-year-old, for example, stays with children in various public health districts, are they restricted to one district to receive their vaccine?
That's a really good question. So I don't, stays with their adult children. Sorry, I was like, how would they be staying with small children? Sorry. Yeah, so it's realistically going to be done by your residents, ideally, because it's the easiest way, frankly, for us to keep track of where everybody is. If they were a worker in a particular setting where vaccine is happening in another health unit, that needs to be taken in mind. And so we've seen that happen many times to this point for workers in long-term care homes. They may live in one health unit, but they work in a home in another health unit. But we're trying, just frankly, from ease, it's much easier to go by their location of residence and that health unit. So I think that's likely what we'll be seeing. If they haven't been living at their primary residence for, months duration, it just needs to be able to, that they can identify to the public health unit. So whether that's through their primary care provider, whether they register under their children's address, there'll be ways to do it, but it's slightly harder if it's not your primary residence.
Okay. Last question or two here. I'm not sure if Nadia was able to join us or not, but this one might be more posed for her, and we can put her in the hot seat for a minute if she's able to. But what are the expectations for primary care? So how involved should they be in vaccination clinics, and should they be minimizing their own clinic priorities to help support the efforts of public health and the vaccination plans? So I'm not sure, Daniel, if you want to take a kick at that. I'm not sure if I'm seeing Nadia here yet.
Sure. No, I'm happy to if Nadia's not here, but yeah, she's definitely better. We are in no way suggesting that you should compromise any of your clinical care to assist with vaccines. If you have capacity, if you're able and you want to help with vaccines, it is certainly appreciated. And reach out to your public health unit and identify yourself so that they know that you're available. But still, clinical care for your patients is the primary concern, and in no way should it be compromised.
Great. And another question here, I think, to end it off. Do you know if funding support for teams who have been asked to take on a significant portion of administration or logistics or vaccination efforts in their communities? It may include HR funding if working overtime, IT expenses for laptops, PPE expenses. Any comments on funding?
That's definitely a Nadia question. Sorry, I really don't have any insight on that one.
Figured as much. She's lucky she's not here, but we can pose that one as follow-up and send that in our communique afterwards if that's helpful to folks on the line. There's a couple other questions here, I think, about medical directives that perhaps we'll do some further digging as well and send out some statements on that. So I just want to take a minute. We're going to try to stick to time here to give our speakers enough time to get through their presentations as well. But a huge thank you for Daniel. It's just so helpful to have you here. We're very much appreciative. As I said, it is very difficult, I think, to stay on top of things daily, and things are so fluid. So really appreciate you taking the time to join us today directly and taking questions from our members.
Yep, my pleasure. I couldn't agree more. It's hard to keep on track. I have trouble every day as well, but happy to help and answer questions anytime.
Great job. Thank you so much. And again, you're welcome to stay on and listen to some of the other stories going to be shared here today. So with that, I'm very pleased to introduce our speakers today, who I said will be sharing some of their vaccination rollout efforts in their own communities, discuss the leadership role being played by primary care, and offer some advice and some lessons learned, perhaps for other primary care providers on the call to consider within their own regions. So first up, we have Jill Berridge, who's going to share the vaccination rollout plan taking place in Hamilton and the role of primary care in those efforts. So Jill, I'm going to turn it over to you.
Great, thanks, Bryn. Hi, everyone. Thanks for having me. So much to try to pack into 10 minutes, so I'll do my best. I'll probably speak really quickly, so I apologize in advance. So I'm going to start just giving you an overview of the high-level plans that are happening in Hamilton and sort of what we expect in the near future. A little bit about primary care and what roles we're playing in the vaccine rollout. And then a little bit about how we got here and some of the takeaways, hopefully that will be helpful for you today. So next slide, please. So the vaccine rollout here in Hamilton, we have about 600,000 people we're responsible for in our area. And our goal broadly is to try and vaccinate 75% of the adult population in this region by the end of June. The vaccine delivery, we got a team together that was a collaboration between the McMaster Family Health Team, Hamilton Family Health Team, our CHCs, public health, and both our hospital systems back in sort of November, December, and we launched our first clinic in December. That was located at a hospital site through Hamilton Health Sciences, but it was actually a collaboration for all of the other components that needed to come together to make that happen, such as the staffing, IT, COVAX, et cetera, et cetera. So that was our first launch. The second launch was mobile clinics that were a collaboration between primary care and public health, and those focused on the long-term care and retirement home injections. So it became apparent pretty quickly just with those two clinics or clinic venues that there was not enough staffing even with that collaboration to make sure we had enough vaccinators in particular to do the work, especially at the Hamilton Health Sciences site, which was doing up to 1,000 a day. So we put a call out to primary care physicians across the city, and I'll explain how we did that in just a few minutes, and had a tremendous response of over 200 people within like the first 24 hours. It was crazy. So we had to really quickly pivot and create a whole new HR sort of stream to manage that, to manage everything to do with the scheduling, the COVAX access, orientation, all of those components very, very quickly. And so that was the lead role that I personally took on, and the FHT admin assistant who works with me is a very key component of. And included in that is we took on getting the COVAX access for everybody in the clinics, not just primary care actually, but for everybody coming from the hospitals and all of the other venues who were helping out. So that it sort of grew very, very quickly into this huge beast, which was very interesting and a little bit crazy at the time. So that's sort of where we started. Where we're going is we have our second hospital site opening up next Monday, and that is a St. Joseph's Healthcare run site that's up on the mountain here in Hamilton. Then we will be further into March launching our biggest community vaccine clinic, which is at the First Ontario Centre downtown Hamilton. It's a large arena for those of you who know it. Then we'll have another offering in the east end of Hamilton, another large vaccine site beginning of April. And while the mobile clinics are continuing, they've obviously changed their focus. We're done in long-term care and retirement homes here in Hamilton. So we are now changing to another broad variety of trying to get the vaccine out to some of our more marginalized communities. So we have a city bus that's been retrofitted to deliver vaccines. We have teams going into people's homes, people, those particularly with mobility issues, transportation issues, going into city housing, different buildings, community centers. We're doing pop-ups, and particularly in the outer areas of the GHA to really get for people that it would be hard to travel into the city for. And we're exploring the drive-through option like many others are. So we're hoping at the height of all of this, probably by mid-April, we are delivering 10,000 doses a day here in the city. The wave after that, we anticipate that should be done by end of June, and then we'll start to turn our attention to the community pharmacies and delivering the vaccine within our primary care practices. So that's sort of the high level view. So how is primary care involved in all of this? I know it's a really busy slide and it is not intended for you to follow really closely. So I'll do my best to just explain high level and why I'm presenting it. So I mentioned we started with a pretty small logistics table, but that had to grow pretty quickly based on the efforts of what we were trying to achieve. So you can see here, this is just our vaccine structure showing sort of the reporting structures and who's involved. And what I've shown here is the yellow highlighted squares are the ones where primary care is involved at those tables and or is leading those tables. And you can tell whether we're leading the table by the blue star. So wherever there's a blue star, that means somebody from primary care is actually leading or co-leading that particular table. So I happen to co-lead the HR management team, but we have people across the board in a variety of the groups. So I'll just quickly go over them because I know it's hard to read this slide. So we are involved in the large scale clinics, the mobile clinics. We actually have a primary care table unto itself. The sequencing and ethics, IT support, and in fact, between IT and our data quality management tables, our quids and several other data leads sit there. Supply and inventory management, vaccine promotion and confidence, adverse events, quality assurance, communications. So we have we're involved really in almost all of the broad scale logistics that are required for the vaccine rollout. We all feed up into the vaccine task force table. So anyone who's a lead sits there. That's where the coordination from the highest level happens. And then we report up to what's called the HCRT triad here. And that triad actually is made up of hospital leadership, primary care leadership, and public health leadership. So primary care is even involved at that level of leadership, which is very exciting. Next slide, please. So how did we get so much primary care involvement in this? Because it's quite a large, there's dozens of people involved at this stage. So as I mentioned, it started off with a smaller leadership team that came from the Hamilton Family Health team, McMaster Family Health team. The Chief of Family Medicine represents both hospital systems for us. It's one position for both hospitals, and then some CHC leadership. And from there, we're actually currently soliciting some involvement from representation for Mock-ins and fee-for-service, because we really want to make sure that, especially as we move to the rollout within practices, we're really thinking about all the different venues that are going to be affected and impacted by that rollout and have their voices at the table. And I think it's also important to mention that we have a lot of non-clinical representation as well as the clinical representation involved in all these tables. And I will just mention that the medical directors for the hospital sites and the mobile clinics are actually physicians. Well, one is a physician from RFHT and the other is a fee-for-service physician. So again, huge involvement there. How have we been able to, excuse me, communicate with such a broad variety of stakeholders? So I've mentioned the leadership team again, and of course we feed things back to our own organizations. But we also have a group here in Hamilton called HFAM, or the Hamilton Family Medicine Group. I'll talk a little bit more about that in a moment. And then the more recently established COVID-19 Physician Volunteer Group. So HFAM is a group that was put together by a primary care lead triad 2 years ago. And so that was the medical lead from the Hamilton Family Health team, from here at the McMaster Family Health team, and that chief of family medicine. They were trying to sort of initiate and organize some sort of a base of contact to coordinate primary care across the city a little more effectively. And so they started this HFAM group, which has really grown and evolved. It's got hundreds of members, and it allows family medicine to connect in ways that they hadn't previously. So we have a website now where there's all kinds of resources posted, guidance provided, people have the ability to ask questions, and there's a town hall that's organized. It's generally monthly, but in COVID times, it's probably been almost weekly, just to make sure people feel connected, get the information, very much like what we're talking about today. So that is one venue where we're able to put calls out for participation, and we're able to answer questions. So coming out of that, this new HR stream, that's the COVID-19 physician volunteer group, that has now grown to include over 400 physicians across the city, and that's primary care and now actually specialists. They were getting a little jealous. We had this whole thing worked out and wanted in. So we've expanded it to include any physician who's working here in Hamilton who wants to participate. And it also includes, above and beyond that, over 100 either non-clinical staff from primary care and our nursing and other allied health professions who are helping with this endeavor. So, you know, quite a large pool that we're trying to work with here. So as I mentioned, I'm the lead for that particular group, and we have taken on all of the scheduling across all of the sites. We have taken on the COVAX access, we have taken on orientation materials, and a lot of that type of work that has to go into getting people ready to work at these sites. And so I'm happy to answer any questions or provide people with some of the tools that we've developed. If that's of interest, you can always reach out to me. So how did we get here? I think it goes back even a few more years, and probably to the Syrian refugee influx of, I think, about 5 years ago now. We, in order to assist that endeavor, the primary care leads, those of us who are executive directors, got together from across the city and really sort of worked with our hospital partners and public health to make that project happen, and really enjoyed that work together, and so have stayed sort of more informally connected. And then when that leadership triad I mentioned sort of came into being, it worked closely with us as well. And so that was sort of the seeds. From there, HFAM was born, and then I think that timing was perfect because of the COVID-19 initiatives that started not very long after HFAM became fairly well established. And so our first connection, involvement, and sort of spread of primary care leadership across the community was with the testing and particularly with the drive-through site that we provided here in Hamilton, but we were involved in, and still are involved in, the assessment and testing components of COVID-19. And so I guess my advice and guidance for those of you who are trying to figure out how do you get your tentacles into all of these tables and places with the vaccine rollout is it's that relationship building, which is really key. The foundation of all the relationships that we've formed and continue to foster have really been the sort of the way to unlock those doors. But it's also done with a huge amount of advocacy. I have to tell you, I can be such a pain to people here in the city, because if I even so much as hear of a table being formed or people having a conversation, I'll insert myself. I'll say, well, wait a minute, primary care needs to be at that table. What are you talking about? And, you know, I might go, or one of my partner EDs or one of the medical leads might go to these tables, sort of find out what it's about. And then if we're not the right person to be sitting there from primary care, there's another expert that we think would be better situated, then we ask them to join that. And it is a lot of work. We have to continue to remind people we're here, we're capable. We actually have some of the best resources for particularly vaccine rollout available at our fingertips. And they need us and our knowledge and our expertise. And then it's building on the successes. I think being able to show that we had success with the Syrian refugee influx, we had success with the testing sites last year, you know, continuing to remind people of those successes. And then the final advice is that sharing information, create a venue that you can share information, because the amount of willingness and involvement that people want to have with with endeavors like this is absolutely tremendous. I can tell you, because of a lot of our current clinics, the physician component may be scheduled, show up and actually be asked to be a screener, or asked to actually check people in, or maybe do anything other than a clinical role, and they're just happy to roll up their sleeves and be part of it. So that sort of amazing input and that amazing spirit of teamwork is really shown, and we're complimented on all the time. And I think, again, that's what we do in primary care. So it's a wonderful way to sort of show and shine with that. So in summary, I think primary care is really involved, if not leading, all the aspects of what's happening here in Hamilton. Every sector and every type of primary care practice is or will be represented. We currently have over 500 people that we're responsible for in this rollout, and we have a really strong communication network that we are using to keep people informed. So hopefully that's helpful.
Great. Thank you so much, Jill. I mean, I think Hamilton is just a really fantastic demonstration of collaboration. Clearly, as you've alluded to, it's been built on relationships sort of pre-stemming COVID. But thank you. I think that's very helpful to share that approach with folks across the province. A couple comments I'm getting here is it really also identifies the differences, I think, in relationship and public health in the different regions, and request here, in fact, for the ministry to be sending a stronger message to public health that they should be involving primary care consistently across the province. So we'll take that back in some of our advocacy work as well. With that, I'm going to introduce us to our next speaker, Robin Mackey, who will be sharing with us on behalf of the Norfolk primary care health teams and sharing the evolving rollout in her community. And I'm just going to say, keep continuing to send in your questions. I may ask one or two at the end of each speaker, but we'll try to hold them to the end and make sure we get through our 4 presentations. Thank you. And Robin, over to you.
Thank you, Bryn. Like Jill, I want to start off by saying that a lot of our involvement with public health has come out, in our relationship building has come out of a need. So like Jill's talking about the Syrian refugee I guess, position they've been put in. Ours was coming out of our seasonal agricultural worker program. So in Norfolk, we have a very large community of farming. It's very rural. We're a small primary care family health team. And with that, we were very much involved with public health through the seasonal agricultural worker program, as well as when the pandemic hit, we were asked to be involved in setting up an immediate testing site and going on site to provide a lot of primary care for this very marginalized population in a congregate setting. So when the position came up for vaccination, we had already established a relationship with public health, and they came to us right away and actually were asking us to set up and roll everything out on our own with them. So we were leading that with them. And we know that as we move forward with different types of vaccination or different types of vaccine that comes available, it will probably switch back more to different providers because it has been challenging to try, as many of you know, to continue to provide your own primary care services in addition to all the extra work that comes with vaccination. So I wanted to just give you a little bit about, most of you know about Norfolk County. We're a very small rural community. We have about 60 to 65,000 population here, a lot of rural. And when we got together with our team, it really is made up of the Delhi Family Health Team. Again, we have about 38 employees, and we have, of those are about 7 are physicians. We worked really closely with public health, our community paramedicine program, volunteer fire, many other volunteers came to the table, and our facilities management personnel when we started to try and locate a facility. Our own location was not optimal for setting up a clinic. So again, we got together with our team and started trying to figure out where we could identify a place. So my presentation here today is very granular and maybe a repeat for some of you who are already running a clinic, but I thought I'd just share it from a local level. We got an opportunity to, once we set up our plan and submitted it to public health, it became part of the plan that went to the ministry. And we put a plan together to try and do what they called a test of function. So we took about, I'm going to say 100 or so 80 plus I guess, patients, and from our different areas of our different people in our physicians. And we turned around and we did this test of function through our clinic to see if we could ramp up. So the pre-planning kind of first steps here are we really leverage those working relationships from the previous assessment center and our seasonal agriculture worker program. We leverage some primary care physician groups, and that came from our OHT. So last year, the last 2 years, we've been trying to leverage our primary care groups, because in our primary care groups, we have one family health team, like I said, with 7 physicians. We have a number of faux groups, and then we have a couple independent physicians. So AFTA was very instrumental in helping us to leverage our OHT initiative for primary care. So it was a natural progression that when we put this call out again to these doctors, that they all stepped up and volunteered for this program. They also, when I talk about the many Zoom calls with multiple leads, we ended up having to go with every single 29 of the doctors, and we reached out to them on behalf of our family health team, and they cohorted their 80 plus patients. We had to work with community and social services and the long-term care homes, because some of these patients may have been on multiple lists. So again, there was a lot of coordination and a lot of patience and communication to go through to get the doctors' list together. We then submitted those lists to public health. We had about 3,500 patients that were 80 plus, and then we've got lists now that go 75 to 80, 70 to 75, 60 to 65. So we've got these increments so we know what kind of numbers we're dealing with. So we ended up locating a site, which was a large community center that had access to internet. We had to have large parking areas. And then we started to pull these multidisciplinary teams together from our community providers. Next slide, please. So again, here is a little bit of a picture of our location that we have. When we were looking at our 80 plus population, we did have to identify that most of our patients would be bringing somebody with them. So you can see a little bit in the picture that we had spots where 2 people would sit together, spots for wheelchairs, spots for walkers. And then when I look at these first steps, we knew we had to follow the ministry and the vaccine rollout protocol, which includes those 5 stages. And I'm just going to go through quickly each stage and then just talk about our next steps. Next slide, please. So scheduling, primary care was used to identify the priority patients for vaccine administration. This was done by our primary care doctors with our family health team. So public health gave it all to us to be able to manage, and we were able to send all the information back to them. We identified the designated appointment dates and times for the vaccination. Again, working with public health on this they would coordinate the amount of vaccine that we would need. We actually started this with simple Excel spreadsheets, because as many of you know, not everybody uses the same EMR. So we did also, through our OHT, identify which doctors were on Oscar or Practice Solutions or whatever system they were using. We know that we're moving to a Practice Solutions virtual schedule, because most of our doctors do have Practice Solutions. So to ease in the administration role, we purchased and added on to our own Practice Solutions a couple of online schedulers that now we would send out the virtual link to the administrative MOAs at each office and say, you've got 240 spots to fit your patients into, and they would book them online themselves. One of the things that I want everyone to be aware is that you need to schedule in your breaks and your lunch hours and build in your 15-minute overlap, because when we get down to the very end, you'll notice that everything shifts about 15 minutes behind. In knowing this, we also, in our team, we put in floats that were clinical floats and a number of other people that could help out with that. So our goal was to have 3 immunizers, 12 immunizations with 36 immunizations per hour. 7-hour day, we're up to 252 immunizations per day at our Victoria location. Next slide, please. So stage 2 is the screening. Very important from a community members to be screened at the front door again upon arrival to our vaccination center. We actually also have volunteer fire. They would receive a document of all the patients that day for crowd control, and they would be able to identify where the patients would park. If they came early, a lot of our seniors may come a half an hour early. They'd be directed to sit in their car until their time came so that we didn't overflow and bottleneck on our screening portion of the administration of the center. So what we ended up doing is if they were screening positive in any way whatsoever, we would notify public health, send them back to the car. They never even came into the center itself. And also to avoid any potential for I guess, spreading of any virus if they were positive, outside before they even came in, every patient had to get rid of their cloth masks, and they were provided by our firefighters with the actual, the masks that we would use for in the clinic, right? The surgical masks. So community members should not be vaccinated if they had any symptoms of COVID-19 to prevent spreading. Again, we just followed a lot from a screening perspective, just straight from the ministry's directions. Next slide, please. So registration was a challenge. So this is our actual registration day. And you can see in the picture, there's 2 seniors that are coming in, both having walkers. We noticed very quickly that with the seniors in the middle of winter, you need to have a lot of mats down. In the very first time we did this in our test run, every single one of us took times mopping up the floor because we didn't want anyone to fall. The mats needed to be taped down. Again, higher risk for that with the senior population. And again, knowing that when your seniors are coming in, they're going to bring somebody with them. So we did allow that and we planned for it in advance. So the collecting and the documentation, including the consent forms, just so everybody knows who hasn't used the COVAX system, we were totally trained in the COVAX system. Again, this was all part of our training and setting all this up in the beginning. The COVAX system doesn't allow the communication of consent for the vaccine to go back to the primary care doctor. So that was a very big issue for our doctors, is to not have that information that they're 80 plus or 90, 100. We actually vaccinated a gentleman who turned 101 on the day he came through the clinic, which was lovely. But there was, in the COVAX system alone, there's no way to be able to identify that to the family doctors. Our family doctors did want to know for this vulnerable sector that they were being vaccinated. So we went with paper-based consents. We pre-consented everybody in advance. We took that information and had it uploaded to the COVAX system in advance of the clinic date, which made, when the patients came through, there was nothing new to them. All they would basically were, we just screened them for their health issues on that date, but they knew everything else. And it was a matter of just ticking the boxes, and we did not have a bottleneck at registration. When the ministry was at our location to watch our actual clinic run, they said that it had run very, very well, and that they did notice that there were bottlenecks basically at the registration and at the screening. So we were trying to avoid that. So again, for anyone who's looking at this down the road, maybe for the younger population, COVAX will be fine at that time, but for the seniors, I strongly suggest that somehow pre-consent is being done, at least in our rural area. We found that to be very helpful. Next slide, please. So the vaccination center, the station itself, there you can see a 94-year-old being vaccinated by one of our nurse practitioners. The public health unit preloaded the syringes for us, making it a lot faster and more efficient. We were constantly back and forth with the number of vaccines to be administered because we don't want any wastage whatsoever. The immunizer reviews the COVID-19 vaccine screening and consent form, confirms their vaccination eligibility, answers questions, provides the education, and ensures informed consent. But when you see all of that, again, that was mostly all done before. So it was really just a quick follow-up with the patient. And most of our patients were in and out of the vaccination within 5 minutes. The biggest lesson learned here is that seniors come with about 5 layers of clothing. So it took more time for our seniors to undress an arm for their 5 pieces of clothing and our nurses to help them redress than it actually took for any of the education and the vaccination. So we got wise to that. And on our calls to the patients for the next clinic that we ran, we told them to wear 1 shirt and a warm jacket. The community member then directed them to the post-vaccination monitoring area. The other thing we learned very quickly about this is they need to wait 15 minutes. And we put a sticky tape on the outside of their jacket that said, and it was for the 15 minutes when they were leaving, because our paramedics didn't want to do the math. So again, we learned that very quickly. The seniors did want to socialize and stay. We had a hard time getting them out because a lot of times this was their first day out. So our vaccination team was made up of the people identified there. We even have our midwife who is able to vaccinate. She was part of our team. So it was fantastic. Next slide, please. The post-vaccination monitoring was done by our paramedics. You can see there, again, a lovely picture. Most of the patients that were coming through were very excited. Our paramedics had a fantastic personality of talking with the patients coming through. Those were being immunized had to stay for 15 minutes. Some would have to stay for 30, depending on whether they had any potential adverse reactions before. We made sure that there was the floater, again, like I said, was a clinical person. We did have a patient fall, no adverse reaction, but we had a senior fall. They got their leg caught up under the chair, and it was great to have the paramedics there. They took them right away to make sure that they were okay. And one of the nurses and physicians at the clinic stepped into the post-monitoring phase. So again, everybody's cross-trained to be able to do this. And then just basically, this is the preparation that we had. And during the 15-minute wait, we had patients have their vaccine medication information handouts, so it made that 15-minute time go fast. And then they received their ticket from the COVAX system, which told them about their second shot. So that's that for that. And next slide. Reconstitution. Again, all I wanted to talk about here is if you can get the 1 ml syringes, they're fantastic. They are the syringes that we chose to use. And we really had to calculate with public health the remaining number of residents to be vaccinated and how many doses are at the immunization stations. And for this, you really need to have a standby list, because you can never, the way that the doses are being reconstituted, you may not have enough, so you have to reconstitute another vial, and then you may have another 3 or 4 doses. So we had a standby list, and we knew the people within that standby list and how close they were to the clinic, and we would start calling them at 3 o'clock to make sure they could be there to 4, so we could get them immunized. And they knew they were on a standby list. If the vaccine was extra, we'd bring them in that night. If not, we'd move them to the next clinic. So again, that's just for efficiencies of use of the vaccine. Next slide. Lessons learned. We had daily debriefs, really extra communication that needs to be done. Seniors take much more time wanting to socialize, fearful of the outing. We actually managed to have picture name tags of all of our faces without our masks on it, and our float, whether you're float immunizer, again, helping with the patients to get rid of that fear and to humanize the experience. You're pushing through 252 at our clinic in a day. We wanted it to still have a personal aspect to it. Again, planning for the caregivers, watching for the slips and falls, having somebody outside for crowd control. And our team worked hard, so I made sure I always brought coffee. Next slide. Very end is question and answers. I know we're going to probably leave that, Bryn, but there's a wonderful picture of our firefighters, again, volunteering, and they were fantastic. So that's it. Thank you very much for allowing us to present.
Thank you so much, Robin. I think that the granular level of detail that you just provided, I think will be so beneficial to many other teams that are struggling sometimes with the small, task. Where do you start? So really, really helpful. We're doing okay with time. I'm actually going to ask you a couple of questions here, just because it's directly in regards to your presentation. But how did you reach the 80+ patients for the unattached or out of town docs?
So we did not do out-of-town doctors. What we did for the unattached is we worked with community and social services and our community paramedicine. So right now, we only have been doing the patients that were on the list from the primary care doctors, and we're working with public health and community and social services to identify and home care services to identify those patients who are unattached, and they will be the patients that are to be done next. And also, the other challenge with this is we've had a lot of questions from homebound patients that even of the patients in the community that have doctors, how do we get to them? And unfortunately, it's going to have to come when we get a different vaccine. So we've been working on that quite a bit. As long as we're only being able to use Pfizer, I should state that it is Pfizer we're using. And because our hospital had the deep freezer, we were able to transport it to our one location. But once it's reconstituted at that location, we can't then take them to and start delivering to home care. So we are working in our vaccine task force to identify those other vulnerable sectors to get them in on this as well.
Okay, thank you. And then what did the booking schedule look like? So how much time per appointment or appointments per vaccinator?
So what we did is we allowed 5 minutes per vaccinator to come through, and we actually worked really well with that. So we had 3 cubicles, if you want to call it, that were being vaccinating, and they were literally in and out within 5 minutes. So we were getting through that. I'm going to say 9 per 15 minutes, which gave us our numbers. And we did trial it first. We did it actually slower, and we found we had a lot of time at the vaccination center or at the vaccination stage. We were struggling at the post 15 minutes because that's based on how much location you have to be able to keep everybody 6 feet apart. And we know with the senior population, Bryn, is that not everybody that's there is getting vaccinated. So when you get to general population, you probably won't need as much of that, I'm going to say, space where people are sitting that aren't getting vaccinated. So we could probably even increase our numbers at that time.
Great. And actually, just a follow up to that then on the seniors. So would you ever recommend inviting seniors in blocks? So like in mornings between 9 and 12 rather than specific appointment times? Have you considered that?
So we didn't. We really, and this is based on our physician group, is we really wanted to make sure we understood at where every patient was. And with our physician group, what they wanted to do is they're volunteering on the days that their patients are in, and then we have extra doctors that would come. So say we've got a doctor that has 250 of his own 80 plus patients, he would come or she would come that whole day. So we were able to not split up the actual physician groups so that the physicians can be there. Because for the 80 plus, one of the things that we noticed a lot, Bryn, was that the patients, once they saw their family doctor, like the face just coming in the door, they're like, oh, there's Dr. So-and-so. And they relaxed and they didn't ask as many questions. And we did feel when we were going through, we did have patients who would start to ask a question in the front end of the screening stage, and we would pull them out of line and they'd go sit with their doctor. And then we could keep the line moving. And then we just would take that patient and put them back into the process. So we were able to not have any downtime by having their own doctor there that day, which was great.
Great.
I know we're small, so I'm not saying that this can be used in large areas, but definitely for rural and for the patient population that we have. We know in Haldimand, Norfolk, there's about 110,000 patients, and we are working with Haldimand, and we're mirroring the same system to be able to do that in both communities, which has also been really great to be able to do that. And the only thing I actually just wanted to add, Bryn, as well, is that we are looking at this type of model for our seasonal agricultural workers. We know we have 5,000 of them coming into just our community alone, and we know that Ontario West has a large number of seasonal agriculture workers, and also in Niagara. So we're looking at how can we take this system and either put it on site, or whether we have access to bring the vaccine to the workers or the workers to the vaccine. So when the timing is right for them, we know that we have a process that we can use already based on this, because working with the seniors, taking a lot of time, is going to be the same that we need to do with interpreter services for our seasonal agriculture workers due to the language barrier.
Great. Well, thank you, Robin. I'm going to move us on to the next speaker, but don't go anywhere. We are going to have some more time at the end, so I will get through the remainder of these questions. But thanks, Robin, again. That level of detail you've provided is just really, really helpful.
Thank you.
So third speaker we're going to hear from today is Michelle Lajeunesse from Marathon Fit, and she'll be sharing with us the approach from her rural northern region. So Michelle, you are up.
Thank you so much, and good afternoon, everybody. What I'll be sharing with you today is just a glimpse of how our family health team has been planning for COVID-19 vaccine rollout in our rural Northern Ontario community, which is made up of just over 3,000 individuals. So next slide, please. So I just thought I would start things off by showing you what healthcare looks like in Marathon. So there are 3 photos on your screen. The first photo, so at the top, is a photo of our hospital. The one in the center is a photo of our family health team. Our clinic is located on the 2nd floor of that building. And we also have a COVID-19 assessment center on the 2nd floor. And on the bottom picture is a photo of our seniors assisted living facility. So in a nutshell, that makes up our local healthcare system. And just recognizing that we would be using a collaborative approach to vaccine planning, and that we would require the support of some of our local healthcare organizations, like our hospital, for example, our primary care team did express our interest in leading our community's vaccine rollout efforts at a very early stage. And we did that because, like in many other rural communities, we only have one primary care facility. So the rostered patients that we have at our family health team make up almost our entire population. So this means that we have access to really helpful information about our population through our EMR, which brings us a lot of advantages from a vaccine planning standpoint. In our community, we're also very fortunate to have a primary care facility that allows us to administer a large number of vaccines on site, which removes a lot of logistical barriers. We also have over 20 years of experience in vaccine administration, primarily through our annual flu shot clinics. And last but not least, because we have regular contact with our patient population and we have that patient trust that is already established, it also puts us in a position to have really important discussions about the COVID-19 vaccine with our patients and to address vaccine hesitancy among our population. So for those reasons, we recognize from the beginning that as a primary care organization, that we are in an ideal position to lead our local vaccine planning efforts. Next slide, please. So now I'll just go in a little bit more detail about our approach to local vaccine planning. So one resource that we found really helpful in the early stages of vaccine planning was the Ministry of Health's vaccine planning checklist. So by using this resource and by relying on our previous experience in vaccine administration, we were able to develop a framework that clearly outlines the roles of our internal staff and healthcare providers, as well as the roles of our key community partners, such as our hospital and public health unit, for example. Next slide. So now I'll just go into a little bit more detail and explain the 4 key priorities that we included in our vaccine planning framework. So as you can see here, our first priority was governance and advocacy, which encompasses the early establishment of our governance structure, including the establishment of our local vaccine planning committee, the identification of our local vaccine planning lead, and also the identification of our key community partners. And as part of this priority, we also participate in weekly district vaccine rollout meetings that are led by our district public health unit, which focus on information sharing and planning assistance. Next slide. Our second priority is communication, and the key action items under this priority focused on providing our healthcare providers and our patients with timely information about our vaccine rollout plan, and also with reliable information about the COVID-19 vaccine. And by doing this, we feel like we were able to take important steps towards reaching our goal of increasing vaccine confidence in both our patients and our healthcare workers. Next slide. Our third key priority was our vaccine administration, and I will touch on this shortly with a few more details. So we'll go to the next slide, please. So our fourth priority, which is monitoring and reporting, focuses on COVAX training and ensuring that we are prepared to meet the necessary internal and external reporting and monitoring requirements. So this is really just a brief overview of our framework, and it's just meant to be an example of how we've utilized resources from the Ministry of Health, guidance from public health in combination with our previous experience in vaccine administration to fully embed vaccine rollout in our primary care facility. Next slide, please. So now I'll just go into more detail about how our primary care team has been preparing for vaccine delivery and administration. One of the first steps that we took was to prepare for our immunization clinics was to begin distributing and collecting vaccine consent forms, starting with the priority groups identified by the Ministry of Health. And to do this more efficiently, we created an electronic consent form. So the link to this consent form can be easily shared and can be distributed widely. And we've been finding that the convenience of being able to complete this consent form electronically and from home has been encouraging for our patients, and they have been completing them in advance and in a timely manner. Next slide. Next, we also made sure to clearly outline the roles and responsibilities of our staff and providers in the weeks and days leading to vaccine delivery. So in the weeks leading to vaccine delivery, our main focus was really on our advanced consent form process, and also on offering our patients, especially the ones who fall into special population groups, with the opportunity to schedule a 10-minute phone appointment with their healthcare provider to review their consent form and allow them the opportunity to ask questions and to also perform a risk-benefit analysis if they wish to do so. And we did that just to ensure that everybody was providing informed consent in advance. And again, in the weeks leading to vaccine delivery, our team was registered and trained to use the COVAX system. And everyone on our team was also provided with a COVID-19 vaccine resource package they were encouraged to review so that they could talk about the vaccine with confidence and provide our patients with consistent messaging. Now, in the days leading to vaccine delivery, which is our current reality, our healthcare providers are still continuing to provide our patients with 10-minute phone appointments if they wish to review their consent form. And our administration staff is calling eligible patients, offering them a vaccination appointment, ensuring that they've completed their consent form. And part of their responsibility as well will be to check in the patient into the COVAX system the day prior to their vaccination appointment. Next slide. So now I'll just go into more details about our vaccine administration plan. So as you can see on this screen, we will require 1 to 2 screeners, 2 medical assistants, 5 immunizers, and 1 physician or nurse practitioner to participate in each of our immunization clinics to ensure efficient clinic operation. So in general, our screeners will be responsible for screening patients for symptoms of COVID as they enter our facility. They will also ensure that each patient is provided with a vaccine aftercare sheet that they will be encouraged to read during their 15-minute post-vaccination waiting period. And each patient will also be provided with an appointment card with the date and time of their first dose, and also with a date and time of their pre-scheduled appointment for their second dose. Our medical assistants will be responsible for escorting patients to our exam rooms, and they will also be responsible for disinfecting exam rooms between patient appointments, and also helping immunizers with any other tasks if they require assistance. Our immunizers, of course, will be responsible for immunizing our patients. When they are finished immunizing a group of patients, they will be responsible for entering the appropriate information into the COVAX system. They will monitor patients for adverse events, and then after the 15-minute wait period, they will also use the COVAX system to check out the patient. Our physician and nurse practitioner that will be on site at our immunization clinics will be responsible for managing or responding to any adverse events if they occur. Next slide, please. So here we just have a scheduling template that we're going to be using for each of our immunization clinics. So as I mentioned previously, we will have 5 immunizers available for each of our immunization clinics. In our facility, we have access to 20 exam rooms. And so each immunizer will be assigned with 4 exam rooms each, and they will be responsible for immunizing 4 patients every 20 minutes. So the immunizers will be staying at that one station for the duration of the clinic, and the patients will be escorted to an exam room, and they will stay in that exam room for their immunization and also for their 15-minute waiting period. And by using this model, we'll be able to immunize 128 or more patients every 2 hours. And if we had to complete a mass immunization, which we don't anticipate having to do at this time, but if we did have to do it, we could immunize over 760 individuals in a 12-hour clinic. So as I was saying, we are expecting our first vaccine delivery next week, so we haven't had the opportunity to test out this model yet. But with that said, it's very similar to models that we've used for previous flu immunization clinics. So we are very confident that we will be successful at reaching our goal by using this approach. Next slide. So I just wanted to wrap things up by saying that just like every other primary care team or healthcare organization or community that has been involved in vaccine planning, we have encountered some challenges during our vaccine planning process. But by taking a proactive approach and by really just focusing on utilizing the resources that we have available in both our facility and in our community, and by relying on our past vaccination experience, and by ensuring clear and transparent communication with our internal and external partners, and also with our patient population, we feel that we've been able to successfully mitigate many of these challenges, and that we have been able to build a vaccine rollout plan that we are confident will allow us to attain our primary objective of efficiently, quickly, and safely administering the COVID vaccine to everyone in our population who wishes to receive it. Next slide. So thank you very much, and I'm happy to answer any questions now or in the question period.
Great, thanks, Michelle. Again, I think some of these tips and that granular level detail is so interesting and fascinating to hear some of the differences in approaches as well. Love the slide that you had on the roles and responsibilities of the staff within the vaccination clinics. I know a number of people have been asking for slides. We will have the slide deck and recording of today's session available within 24 to 48 hours. And just one question for you, Michelle, in terms of consent forms, so you mentioned that you guys emailed yours out. Was there any worry about seniors being able to complete the forms or print them out or access email?
Yeah, so that's a good question. When we started calling our calling list focused on seniors who were 80 and above first. So what we did is we offered to provide them a consent form and ask them their preference. So if they preferred a paper consent form, we offered to mail it to them. But if they had access to email and felt comfortable using email, then we would email it to them. So for everybody, we'll be asking their preference. But for us, from an administrative standpoint, it's easier for us to deal with the electronic consent forms. But of course, we're more than willing to offer paper consent forms to those who wish to fill it out that way.
Great, thank you. All right, lastly, I'm going to introduce us to Terry Arani from the Toronto Western Family Health Team to share primary care involvement in the mobile team vaccination approach. So over to you, Terry.
Thank you, everyone. So I'm really going to try to focus the story of what I want to share is to either highlight primary care's role up till now and our role within the pandemic on a very high level, particularly for the family health team, and as well as share some of the work we've done within mobile, but I'd like to kind of share what the learnings are or some key points for people to consider as primary care becomes more engaged in this important work. So I will try to do it quickly and then move on from there. So actually, if you can just go back to the other slide very quickly, sorry. What I'll be talking about actually has a lot of different health partners. As was mentioned before, everything is kind of governed by the public health units. Toronto Public Health Unit is large, and you will see that there are a lot of big institutions here. So many of the successes that we've had is, but how does one create partnerships from very large, very structured organizations? If you could just flip to the next page. So a little bit of a story ahead of time. So each hospital partner has long-term care and retirement homes and congregate settings in Toronto that are kind of linked with it. Prior to the vaccination rollout, we've already had a lot of partnerships around COVID screening. So the family health team is integral and runs the COVID assessment center. And our primary care physicians had already partnered with a lot of the long-term care homes to be helping with swabbing, surveillance, screening, et cetera, et cetera. So we already had a lot of partnerships. So at UHN in around December, knowing that the vaccine was coming, there was very much looking at what are the phase one. So I'm not going to talk about the standing clinics, the large vaccination clinics. I'm going to talk a little bit around vulnerable populations. So there's two aspects. It's really around mobile vaccination clinics. And it started up with the vaccine hit the freezer farm on the 29th of December. And then we went out on the 31st on New Year's Eve to start vaccinating. So it's very much a bit of an organic story and a lot of the lessons learned. I won't go into the specifics, but when you actually look back, yes, there's lessons learned, but it's very, very organic. So I wanted to share here that the family health team and primary care was involved very much in the phase two vulnerable populations. If you hit the next arrow, you'll see I think a big green square open up. Can someone click for me? Am I the clicker? Okay, next slide, please. Okay, there we are. Thank you. Next slide, please. So this is just a bit of a picture of our mobile team. So really, if you took a look at our mandate of our team, it was around right now, seniors, let's get them vaccinated. Very much a partnership. So this is kind of our mandate that we're looking. And we very much took the approach is that we are being invited into someone's home. We are there to support. We are there to assess. We're not there to take over. How can we help? And this is when it was brand new to the retirement homes about consents, COVAX. What is that? It was really interesting in the beginning. If you can flip to the next slide, please. So at a very, very high view, I just wanted to share the structure. So we actually had a joint operations group because it was very complex for people who are aware about the complexity of each of the individual vaccines. And I'll talk about it after because that's one of the things to consider when you look into your how you're going to be partnering and what you're going to be doing around vaccine delivery. So primary care, i.e. myself as the ED, as well as our chief, was very much involved in our daily joint operations center. So that's kind of the structure. And then, of course, we are the mobile vaccination team that went out. Can you go to the next slide, please? Yes, there's my little green square. This is a very busy slide. What I want to share is that there's the site leads would contact the homes, get as much as information that you can, order the supplies of the vaccines. We would create to-go kits, and I'm happy to share what we had in there, and then we just showed up the next morning. We actually did the draw and everything else of the vaccine ourselves. We were working with Moderna, so we had a core of nurses. So if you create a mobile team, the importance of having some people who are consistently there. So we had physicians, primary care physicians sign up for half days when they were available to help administer, but we really had a core small nursing team that did all the medication management and documentation, et cetera, et cetera. So that just kind of goes through all the different steps. You can flip over that. It's a bit busy unless people have questions. Can you go to the next slide, please? So high-level learnings, really, we were looking at speed and safety, right? We did not have time to work through the protocols and what's best. There was like not a lot of planning. It's around let's go in and iterative learning. There are a lot of conversations back and forth. We were ready to go. Does Toronto Public Health allow us to do retirement homes? Are we not? Can we do it as a pilot? So it's very, very early. And the vaccine logistics, particularly because we had a no dose wasted policy, and with the counts, like it's those pieces. You would think that asking a home what are the number of consents that they had on file or that they got, the numbers changed all the time. So it was well-controlled chaos. So it was really much around a PDSA and success. We were actually, with one site team, we would do anything from about 300 in a morning to going to multiple sites. And the other thing I want to share after, as you're considering, there'll be a very different piece around a dose 1 and a dose 2 strategy. Even with long-term care homes, it's amazing how many people are no longer there in 28 days, and you have to find them and get their dose to them with the idiosyncrasies of each vaccine. Can you go to the next page? So high-level lessons learned, continuous conversations, a lot of the really great things. So for example, what I want to share as a learning is make sure that there's direct communication between your clinical team, whoever they are, all the way up to the upper logistics. The Ministry of Health, when they looked at their emergency supply list, gave 3 ml cc's, 5 ml syringes, blood needle tips. We learned going right in there, going, oh my God, there's massive waste. So just because in primary care we had used the integrated syringes, we very quickly discovered that we could get the 11 doses. Very quickly we spoke to logistics, and we actually got our hand on the Vantage Point syringes. This is where you don't have the separate lural lock, no dose. So by these conversations that we've had, and we had a logistics team that was advocating was be able to do all these large bulk purchases, we were able to very quickly increase 10% to 20% more vaccines available. So that's really the high level. I want to talk a little bit around what are some of the things that you may want to consider as you get involved in vaccination. So if you can flip to the next slide. So sorry, the other big piece, because you may wonder, is there value in doing the mobile? It's a lot of work. What we actually found was the ability to deal with vaccine hesitancy, particularly with staff. We actually ended up going back a couple of different times, because even although there were large clinics available for staff to go to, people weren't going. So when you really think about the value of primary care, able to have those conversations, that touch, that piece, that's the magic sauce that's different than a mass vaccination clinic. Like there's pros and cons to both, but I really wanted to share that having clinicians, having to share that conversation, having a staff member see their friend in the kitchen saw they had it done, we were able to really bring up the vaccination percentage rate of the workers at the facilities, and that trust piece. It also really strengthened the relationships. There's a lot of walls between various areas of health, and we found this brought us together. If you can bring it to the next slide. Okay, so these are the things I just want to share that I would recommend, but a lot of people reach out to consider. First, where are your partnerships? Who are you working with? Everybody's vaccine strategy will look very, very different. Everybody has a different model. I think that I'd want to say nobody has 100% figured this out. So I think who are you working with is a key piece. Some primary care environments are being called and saying, here's a space. do it. Some people are saying, hey, you run the whole thing. So I would say really decide clearly who are your partners and what is your role in this partnership. Really, infrastructure supports. The issue here is not injecting the vaccine. The challenge is the logistics. So I'll talk a second about COVAX data entry because we went from paper COVAX after to COVAX in the moment. So I think that really, if you're planning, really understanding start to end, particularly with dose 2 considerations, because that's a totally different kettle of fish. So really think about what does that look like and what is being offered to you. Also think about which vaccine, so 1 or 2 dose, the handling requirements for Pfizer or Moderna. A lot of people are not, you may know that it needs to be frozen, but what does that mean? That you have 6 hours post-puncture time. What does it mean that once it is thawed, you cannot deliver it, you cannot move it more than 10 minutes? What does really no jostling, no touch mean? How are you labeling every single one? It's very different if you are physically close and you have a pharmacy or public health that is giving you all that stuff and handing you a syringe. That's a very different process than if you're getting frozen vials. So I think really understanding what vaccine you're working with will help work out your processes around that. I think too, what is your target population? I'm hearing from a lot of public primary care environments is like, we're being called in to help. Well, what are you, I would say question, what does the public health unit want from you? Do you want to focus on the patients that are attached to you? Is this more of a community? Are they looking for staff to pop in? So really get answers around that early, because otherwise you're starting from scratch. So really that whole piece, what is your role? What do people want? I think is really important for you to define, knowing that that is going to change over time. So the other thing that I would say is, because we're involved in a lot of rolling pilots, like what you expect for next week, it might be something totally different. So create a bit of a flexible model because the world changes. One of the big things that was a learning, I'll tell you about that in a second. Yeah, so one of the biggest things is COVAX. So to all the clinicians among us who have practiced, it is not the act of the care, it is the documentation of that care, which is the challenge. So a lot of challenges. So we started, because we were running thousands, like we just ran through, we started up by training people admin as well as other people for COVAX data entry. So one of the things I would also want to share is when you start up, sometimes it's like who you have to help, and then figure out after who the right person is. And each different OAT and group did things differently. Like, for example, Michael Guerin would have nurses who did there for the COVAX entry, other groups. So don't get so fussed about who's doing what. Think about what that role is. And in any type of a clinical sit down, I would say your ratio would need to have about 2 to 3 admin around documentation and registration to every single vaccinator. So I think that I don't want to go too deep into it because it's mentioned on the earlier pieces, but really think about the role and how it fits into your unique space. And that's all I'm going to say, because I know that we're near the end of time and questions. So I know that, so what I would say is our pharmacy department is very integral at UHN, our director, he's on the calls. There are a lot of questions we had saying, here we're talking about this was so valuable in the beginning that we actually returned the empty vials to the main pharmacy because there was a concern that empty vials going out would be a risk. All right, so we also have to realize we're in a different world right now than we were 2 months ago. And we had questions. We were sitting there going, seriously, same lot number, same vial, same puncture time, why can't we mix between the 2 doses? So there's a lot of questions. So we're trying to keep push back, but there's certain things that you must follow, but we're still hoping that that may be changed as the province and everybody else has more experience with the different vaccines.
Great.
I will stop now.
Thanks, Terry. Some great final comments and planning considerations for folks on the line to consider. So thank you for sharing that. I think your quote, well-controlled chaos, perfectly summarizes the vaccine rollout these past few months. So thanks for that. I'm going to take that one away. We only have about a minute left. I just want to ask Terry one quick question. What did you receive from the public health unit in terms of your training on the COVAX handling, as well as the training on COVAX itself?
we didn't receive anything particularly directly from the public health unit. We had to create internally a subgroup that would provide training and administrative support. In other areas, other public health units may have that ready. We didn't have it ready at that time. So right now in a joint operations, we have training, but I think by this point, there should be training available. I'm happy with anybody here. If you have random questions, to reach out and I will try to connect you. Totally acknowledge that Toronto Public Health is quite a different beast than other areas. You may have a very different approach elsewhere.
Thanks for that. So we are at 2:30 now. I just have actually one final poll to ask everyone listening on the line today. We know that primary care is obviously stepping up in other regions too and playing an intricate role in vaccination efforts and rollout. So wondering if folks would like to hear more stories from other regions in terms of their efforts in vaccination rollout and the role of primary care. So just quickly here, yes, let's do another session similar to this. Yes, maybe another session in the spring, or no, we've heard some great stories today and it's given us enough help and advice to move forward. We'll give you a second there and Beth will close that off. Okay, well, we're closing that. I just wanted to say a huge thank you to the 4 speakers today. I know it is a very busy time, so we really appreciate them and their willingness to participate today, share their insights and advice and tips to other primary care providers across the province. I think this was more than beneficial. I know there's a couple questions outstanding here. We will do our best to provide some additional feedback and follow up with the speakers and get those out to everyone on the line today. As I mentioned, we will be sharing the recording of today and the slide deck as well. I know there's lots of useful information in there. Hope to get that out actually this evening. So thanks again to our speakers. Good luck, everyone. If you want to get in touch with them, please contact me and I'm able to make that connection for you. Have a great afternoon and hopefully enjoy your weekend.